Hello everyone, this is Holly Lemaster. I'm the Program Coordinator of the Colorado M.E.S.A Initiative. Welcome to our webinar today. We're going to be talking about diagnosing memory loss. Just a few quick housekeeping items before we get started. I want to direct you to your GoToWebinar control panel, which is probably floating at the upper right corner of your screen. You can always minimize that if it's in your way by clicking the orange arrow. And if you're having any trouble hearing us, you should be able to hear us over your computer's microphone and speakers if you have that available. But if not, if you're having trouble with the audio, you can always call in to the number that's listed here on your screen and that also appeared in the reminder email that you received with the access code and the webinar ID from that email. You are all currently muted, but we will give you the opportunity to ask questions at the end of the presentation. And you can do that by typing into the question box at the bottom of your control panel screen. I also want to remind you that there are handouts available for this webinar at the Colorado M.E.S.A website. You will need to sign in and go to the events section and then upcoming webinars, and you'll find out the handout materials there. On Monday, we will have this webinar archived, and it will be posted under the classroom section and webinar archives, so you can watch it again or share it with your colleagues at your leisure. Our speakers for today are Dr. Donald Murphy, who is one of the founders of the Colorado M.E.S.A Initiative and of the Senior Care of Colorado practice, as well as Dr. Clemencia Rasquinha, who is also a board-certified geriatrician and a leader in the Senior Care of Colorado IPZ practice. So I'm going to hand it over to Dr. Murphy to tell you just a little bit about the Colorado M.E.S.A Initiative before we get started.
Thanks, Holly. Yeah, Colorado M.E.S.A stands for Medicare Experts Senior Access, and our goal is to help clinicians be adept at Medicare coding and documentation so that everyone's paid fairly for the good work that they do. We're hoping that providers can be comfortable serving patients with dementia and other geriatric syndromes. This is a collaboration funded by the Colorado Health Foundation, Kaiser Permanente Foundation, and Caring for Colorado. We work closely with the Alzheimer's Association and the Colorado Chapter, and it's the Senior Care of Colorado IPC group that provides the faculty members for this.
And moving on into memory problems, it's just one of the most common complaints that we as geriatricians find with our older patients. There is a lot of concern amongst older adults whether they just have age-related forgetfulness or if they really could be having symptoms suggestive of dementia. A topic that's come up frequently during previous workshops is when really should we be concerned in checking for memory loss? How could we do this effectively in our clinical practice without it taking too much time? We will also look to cover some of the common medications and treatment plans for Alzheimer's dementia, when a referral is appropriate, and want to point everybody to the Alzheimer's Association, which is a wonderful resource for both patients and families. What we don't want to do when people complain of memory loss is to ignore the problem, because it continues to lead to a lot of confusion, for lack of a better term, and more worries. I think a lot of providers are concerned about paying too much attention because they're worried that it might take too much clinical time and they may not have time to address all of their problems. And given that elderly patients usually have multiple other medical problems like congestive heart failure and diabetes, memory loss sometimes tends to take a back seat, although it can have a profound effect on their function. So some providers are also concerned that they don't really want to be the bad guy and have to tell the family members or the patients that they potentially have dementia. However, we do want to point out that this is very easily done in a clinical practice, and should it take longer to counsel both the patients and family, then Don could speak to you more about Medicare reimbursement from a standpoint of time-based billing, counseling, and coordination of care.
Yeah, I'd just like to point out, Clem, sometimes we get the hint that something's going on and we simply don't have time to address it during that visit, but it's good to kind of make a note of that so that we can revisit it later.
Right, and bring them back maybe for a visit just to address their memory loss. When then should we be concerned or checking for memory loss? We might have a little disagreement amongst the faculty members here with most of us feeling it should be done on a regular basis. Annually may be overkill in the well elderly, but I do want to remind you not to get a little too complacent, even with people you know, that we often get so familiar with them that we ourselves may not recognize that there is a problem. So every now and then, do ask the patient or their family members if there is a concern for memory loss. And like with everything else, a good history is truly our best diagnostic tool. The annual wellness visit, are we talking about that yet? No, but we could get into that later. One of the easiest ways to talk about memory loss is to ask the patient and family members, are you concerned about memory loss? Because by the time they get to complain about it, we've found that they've actually lost a significant I'm missing the words here when we said by the time they're disoriented to month and year, they may have at least moderate to severe Alzheimer's disease or dementia. So we're already behind the curve here, I think is the point we're trying to make. Another clue could be when patients begin to skip visits. Usually this happens with well elders who are living by themselves, who may not show up for a visit. If it is becoming a pattern and they have no reasonable excuse, that we should be concerned that there could be memory loss here and it could be impacting other areas of their life. The testing for cognitive impairment actually is now a requirement of Medicare's annual wellness visit. And you want to talk about that, either Holly or Don?
Well, other than just let you know, we have folks on this in our website. We would direct you to that as far as the annual wellness visit. But as you point out, Clem, CMS is making it clear that they want us checking for this on an annual basis.
So it really is a simple thing to do. The 3-item recall and the clock draw test now make up what is called the mini cognitive assessment. This is extremely sensitive and specific for picking up cognitive impairment. And if we have to go to a 1-minute naming test, also called the Milner's, as the name suggests, it takes just a minute to do. The 3-item recall is easily done in the office setting. The medical assistant can actually give the patients 3 set words at the time of check-in, and the provider can then ask the patient to repeat the words during the visit. Or you could have the patient do a complex task such as a math problem or the comprehensive questionnaire in between. Just ask for a little period of time to have passed and then ask the patient to recall those 3 words. 2 out of 3 is usually normal. However, if you have to prompt the patient or they cannot remember the words at all, then we do need to know that this is abnormal and we need to screen them further. The clock draw test is also very simple to do. Either the provider can draw a large circle or you can have a large circle that is pre-drawn on a piece of paper. Instruct the patient to put in the numbers into the circle where they would fall on the face of a clock, and then to put in the hour and the minute hand to indicate the time to 10 minutes past 11 o'clock. Now, these tests can be very specifically scored with a point going for whether the numbers are in the correct position, whether the hour hand, and the minute hand are also appropriately placed. You can easily find ways to score the clock drawing test on the internet. One of the important things with the clock draw is that patients who have a normal clock draw, that can change over a period of time. So this alone can be used as a cognitive screen. Going back to the 1-minute naming test or the Milner's, this is an interesting test. We usually ask patients to name as many animals as they can in 1 minute. What I encourage people to do is to write down their answers and see if they can name animals. Usually 17 plus animals is normal. You'll find that in dementia, people tend to be rather repetitive, starting with common animals such as cat, dog, mouse, and then go on to say, did I say cat? We see different patterns there. Sometimes when someone is cognitively intact, you'll also find that not only are they able to name animals, but they can also group them well into farm animals, zoo animals, or animals seen commonly in the wild. That also gives us some idea of their executive function. So,
yeah, and I would just add here, Clem, that although the clock drawing and the three-word recall are very simple and efficient to do, this one is my favorite. It's 1 minute, and you know if someone's stumbling trying to come up with 8 animals, you got a problem. 12, probably so. 15 or more, okay, they're all right.
It is my favorite too, because it's fascinating. To the savvy provider, it gives you so much more, like I said, just in their vocabulary, but also the executive function.
Right.
So get familiar with this test. The most common test used out there, and I still get a lot, is the mini mental status examination, or the Folstein MMSE. This test really was not developed specifically with dementia in mind. It's a 30-point questionnaire. It takes about 10 minutes, but honestly, if it goes over 4 minutes, that itself is an abnormal test, because they should have done this pretty quickly. So if you're into the 10-minute zone, it's already abnormal. However, this is a copyrighted test, and people may not know that they owe the Folstein Fund $1 every time they use it. But that's not the reason to not use the test. It's just not the best screen for cognitive impairment, was not developed for it. So I would make a pitch for using the three-word recall, the clock draw, and the Milner's. Should we also talk about the St. Louis University mental status evaluation, or the SLUMS, SLUMS, found easily on the web, not copyrighted, and developed specifically with dementia in mind? One more form that is there is the self-administered gerocognitive examination. This really is more specific for the well elderly, or people who are really concerned about memory loss but may not have true dementia. You can find it under SAGE or the SAGE test. The patients can take this home or just sit in a quiet room and answer the questions. The provider, and the scoring can be found on the internet as well, can then score the test and then lead into whether they need further diagnostics or not. However, we put this in there with a big question mark, because people usually think that they need to order some kind of imaging, and the neurologists will usually say we need to get a CAT scan or an MRI. However, we would urge people to use their clinical judgment, and if you find that there is a neurological impairment, or if there is a history of falls or a rapid decline, that would be a time to go into ordering imaging such as CT scans or MRIs, knowing that a lot of people, these are expensive tests. They may not be able to lie still for the test, so you may not get the information you're looking for. So unless you have a strong clinical suspicion for something else being there, you don't have to rush into imaging. Anything, Don, to add to that?
I agree. In primary care, I do not think that we need to routinely get this at all. If you have a patient who has a very consistent history with Alzheimer's, nothing suspicious neurologically, it's so unlikely that this will show up something. On the other hand, if you have someone with a number of cardiovascular risk factors, you wonder about multiple infarct dementia, and you want to get a better sense of how much paraventricular white matter disease they have, whether or not that's going to affect what you recommend, you might consider it. But you can pretty much rest assured that if the patient goes to a neurologist, they're going to get some kind of imaging. But we in primary care don't necessarily have to do that if we really think the yield will be so low.
And even with multi-infarct dementia, it's really not going to change the course of what we do, treatment or management-wise. More importantly,